Start out with an invocation. Let us pray. Gracious and loving God, we thank you for your blessing us with this day and this gathering. We thank you for every person who has come together with a shared purpose to learn, to grow, and to take better care of our lives you have entrusted us. We ask for your presence to fill this place, guide every conversation and every heart toward healing, understanding, and hope. Lord, bless the doctors, the speakers, and all who will share their knowledge today. May their wisdom bring light and life to those who listen. Strengthen the men who are here, reminding them that care for their health is not a sign of weakness, but of courage and love for themselves, their families, and their communities. Be with us through this symposium. Let it be a time of connection, awareness, and renewed purpose. And when we leave this place, may we carry forward the spirit of care and the compassion that binds us together. In Jesus' name we pray. Amen. My name is Rev.Dr. Aaron Best. I am the founder and senior pastor of St. Matthew Baptist Church. And it is truly a joy and honor to gather with you today on behalf of our church family and our wonderful partners at Bridgeport Hospital. We have been working together since 2016 and have relied heavily on them, especially through the COVID pandemic. I want to thank each and every one of you for taking your time to be here for this very important health symposium. Today's gathering is more than just a meeting. It's an act of care, awareness, and empowerment. We've come together to have an honest conversation about men's health, particularly the issue that too often go unspoken: lung cancer, prostate cancer, and colon cancer. Some facts, and the doctors are here and they can correct me if I'm wrong because I am not above correction. Lung cancer in Black men have 11% higher occurrence than in white men and have a higher death rate as well. Colon cancer in Black men have a 20% higher occurrence rate in Black men than white men, and the death rate is higher as well, 40%. As for prostate cancer, this is the largest disparity. Black men have a 67% higher occurrence than white men. Too many of our fathers, brothers, husbands, and friends suffer in silence of waiting too long to seek help. It's not uncommon for men to put off doctor visits, to ignore symptoms, or to believe they are simply too busy or too strong to need a checkup. But we know that real strength includes taking care of the life and body that God, or whoever your divine source of inspiration or power is, gives you. Our goal today is to change the mindset where we can encourage every man to take control of his health, to ask questions, to get screened, and to make wellness a priority. By doing so, we not only protect ourselves, but we also protect our families and our communities that depend on us. So I invite you to relax, listen, and engage with our speakers and the medical professionals who have joined us to share this wisdom and expertise. May this symposium be a source of knowledge, inspiration, and hope for all of us. Together we can build a healthier, stronger, and more informative community. And with that being said, I would like to introduce to you Ms. Ann Diamond, President of Bridgeport Hospital. Following her will be Dr. Victor Morris, Chief Medical Officer of Bridgeport Hospital.
Wow, thank you very much. All right, well, good morning, everyone. I'm Dr. Ann Davila Casas Diamond, and I'm the president of Bridgeport Hospital. I'm really very happy to be with you here this morning, and it is my great pleasure to welcome you to Bridgeport Hospital in the 2025 Men's Health Symposium. We are honored to host this important gathering today here in Hollander Auditorium, and I want to thank each and every one of you for taking the time to come out and be here Your presence speaks volumes about the commitment to health, your community, and the power of shared knowledge. This symposium is more than a series of lectures. It is a call to action. Men's health often takes a break and a backseat to our busy lives. And today we are here to change that narrative. We are here to listen, we are here to learn, and to empower one another with the tools and information that can save lives. I want to extend a very special thank you to Rev.Dr. Aaron Best, who not only initiated this event, but will also serve as our MC today and share his personal story. His leadership and courage are an inspiration to us all. I would also like to be grateful and thank our distinguished speakers that are here today, Dr. Stephen Kardos, Urology Section Chief and Surgeon, Dr. Junyoon Julie Kang, who is going to be speaking on prostate cancer treatments, Dr. Daniel Levy, addressing colon cancer signs, symptoms, and treatment, and Dr. Dan Rudolph, who will share some insights on lung cancer. Each of these experts brings not only their clinical experience and their compassion, but also just an amazing amount of caring and just personal dedication to the patients and the families that they serve. I'd also like to acknowledge our planning committee, including Jean Brown from our Park Avenue Smilo, and Martha Judd, who is hanging out in the back there. She is retired. She is still here today. Give it a round of applause. Thank you, Martha. I was so happy to see you today. I just sent her an email telling her how much I missed her. So as we begin, I encourage you to fully engage, ask questions. You have all the cards that are there. Please write them out. I'm happy to run up and down and pick those cards out when we get to the Q&A section. Share your experience. Please take advantage of the experts that are here this morning. Whether you're here for yourself, you're here for a family, just simply to learn. I am asking you to be part of the movement towards better health and stronger communities. So let's make today very meaningful. Thank you and welcome to the Men's Health Symposium. And I'd like to introduce Dr. Victor Morris, our Chief Medical Officer here at Bridgeport Hospital. And he is also on service today. So he's taking care of all those patients, and we have a full house that are upstairs right now. So to you.
Hey. So Dr. Reverend Best and Ann said everything I was going to say, but I've got some other facts for you. Men in general delay seeking their preventative care and screening. Men have a higher rate, all types of men have a higher rate and incidence of mortality with colon cancer, but are less likely to be screened than women. For lung cancer, it's the same thing, higher rate of mortality and death, but are less likely to be screened than women. But men are not to be outdone in prostate cancer. They are more likely to be screened for prostate cancer than women. But not enough get screened. And I think Dr. Kardos is going to tell you about that. So we have a great opportunity here to improve the screening. Again, screening tests, just so all of us know, a screening test is a test where you can detect the disease when it's asymptomatic. You have a treatment that can improve the outcome, you have a treatment, and that treatment can improve outcomes. And what they're going to talk about today fulfill those criteria. So that's a great thing to have. Just want to tell you a little bit about each of our speakers. We're very lucky to live in an area with outstanding doctors, very well educated, very well trained. They've been at some of the best places in the country. Dr. Steve Kardos went to Georgetown for medical school, did his residency up the road at Yale, did a fellowship in urological oncology and robotic surgery at City of Hope. City of Hope is a large cancer hospital in Southern California. Dr. Julie Kang, and there's a theme here. Some of us are Californians. We got her MD, PhD from the University of Southern California, did her residency at UCLA. I think you were at Sloan Kettering for a little bit before you came up to Yale, again, doing great work. Dr. David Lavy went to Ross, did his residency at Monmouth, and did a colorectal fellowship at Cleveland Clinic, another top spot. Dr. Dan Rudolph, where's Dan? Oh, there he is. So Dan, I asked him earlier, if all these people, the same people sat in the back row in grammar school, they all said yes, but they all said they got A's. What happened to you? All right. Dr. Dan Rudolph went to NYU for med school, top place. SUNY Stony Brook, another top place, and did his fellowship at Einstein. So we have a lot of people with a lot of experience, great care, and really good people to have speak with us today. So hopefully we'll get started. I'm not sure who's first. Is it? Oh, yours first, of course. And I'm also happy that I didn't have to follow, because when you follow a reverend, they got these booming voices and this charisma. And so I was glad Ann went after. So, all right, thanks. I'm going to go discharge patients. Thanks. Yeah.
I don't have a booming voice. Dr. Morris has basically made the introductions to the doctors, and because of time, if the doctors don't mind, that will be your introduction. Is that fine with you guys? So because of time, so our first presenter will be Dr. Stephen Kardos.
Good morning. Right. And it's wonderful to have a full crowd here. We'll give some highlights on prostate cancer screening, early detection. I want this to be very informal. If anyone has a question, anytime that you guys want to jump in, just ask a question. More than happy just to kind of slow down and answer anything that you guys wish. We know that, as we mentioned in the talks earlier, prostate cancer is one of the most common cancers that men actually face, but yet are oftentimes underscreened for various reasons. We know that prostate cancer is the second leading cause of death in men as well, which is very important. And as highlighted earlier, there are a lot of disparities in prostate cancer. In fact, as you mentioned, African-American men are twice as more common to develop prostate cancer for various reasons, but most importantly, they're twice as more common to also, suffer serious complications and even death from prostate cancer, which really highlights the importance of preventative medicine, highlights the importance of breaking down those barriers and actually seeing your providers. Various risk factors for all men are just men who have a first degree relative with prostate cancer, the incidence is higher. We also highlighted the facts that, certain racial, disparities exist that we, really pay attention to and really focus on, which is very important. We know that there's certain genetic syndromes. Genetic counseling is a very big portion of our, multidisciplinary care within our Yale system, where, people with certain genetic syndromes like Lynch syndrome or, the BRCA gene mutations, family history of breast cancer, ovarian cancer, these are patients that we really highlight for, pretty extensive genetic counseling, which is very important. Screening is very easy. People think that, you're going to the doctor's office and you're going to get poked and prodded and have invasive things done, but it's as simple as just a blood test, a blood test that really detects whether or not there's any abnormality that warrants further workup. Does not always mean cancer. There's various benign reasons why the PSA number also goes up. And just a physical examination, nothing invasive, it's just going to the doctor's office, getting some blood work, and just having a simple exam is, all that you really need to do to kind of get the ball rolling. As we said, there's a lot of controversies on prostate cancer screening with, over diagnosis, over treatment. They've kind of changed the way that we screen patients and how we screen patients. But the bottom line and the fundamental approach that we follow is, we need to be screened. And, we've learned as a profession in how we treat patients, how we manage patients. I have, patients that are in their 40s or even early 50s that have prostate cancer that we don't treat, that we think is a low-grade indolent process that we just need to monitor and screen to make sure it doesn't change. So that's one of the biggest kind of misconceptions that we face. God forbid, if there is any problem or any clinical concern, we don't jump to anything radical. We've really, especially when I was a resident, close to 15 years ago, we started doing very highly sophisticated imaging, imaging that can give us ideas as to if there's anything suspicious or anything abnormal. So it really kind of precludes the need to do invasive things unless absolutely necessary. So we have so many tools that we can use. And, you know, our health system in the region was one of the first ones to adopt these multi-parametric MRIs. You know, we're, you know, within our Yale community, especially Bridgeport Hospital, we're more or less a destination center where people come to for these high level of images and even, you know, diagnostics that we do just to diagnose the prostate cancer. I think we're definitely at the forefront of it. You can see how prostate cancer can happen in many different regions of the prostate, and the imaging can really help us, you know, find those spots and spots that could be missed that were historically done, you know, in older fashions, which is important. Let's see, so just kind of some general rules of thumb, you know, prostate cancer screening, there's different guidelines give you different recommendations, but generally speaking, you know, men between the ages of 55 or 69, or at least a 10-year life expectancy should be screened. You know, I see men in their 80s that come in, or 85, 90 that get screened. I'm not going to be the one to tell them that they're not going to live 10 years. So as long as you use informed decision making, you really make decisions with patients. I advocate for screening and just using that as a guide. You know, the PSA numbers change throughout the decade of life that you live in. So, you know, a man in his 80s, a PSA of, you know, 7 or 7.5 could be normal for them. So it's you know, one of the most important things that we should do. Certainly men with a family history, certainly men in high risk populations, you know, should be screened earlier. Some recommend screening at age 40. You know, if you have a high family history or a high risk patient population, screening every couple of years is sufficient just with a blood test. And anytime there's anything abnormal, you know, we have such a great network of medical providers where the primary care doctors will send you to the urologist, and it's just about being comfortable and knowing that we have a lot of options and options that are non-invasive, and it's just more about making a diagnosis. Any questions?
Thank you for your presentation. There's a lot of misinformation about the PSA testing. And, you know, you go to one specialist, he'll tell you another. I'm 82 years old. And they said, oh, you don't have to worry about having a test because of your age. But at the same time, I'm a person who's very analytical. And I want to know exactly what are the thoughts, what's the prevailing thoughts, if you will, with respect to this test? Is it something that should be ignored? You're talking about the 10-year kind of.
Yeah, that's a great point.
Exceeded that 10 years, so.
You look like you have 10 more.
But help me, because as I speak to family members, etc., I like to give them the right information, because as a family, we read a lot, we listen to the medical reports, etc. Because in my family, we have 4 and we're all over 80 as a family.
Yeah, a couple of points that I want to highlight with that. There's a lot of information out there. So patients often come to us fairly educated, and we're having high-level conversations with patients, which we as physicians don't find that as intimidating. We actually like that because we're able to have good conversations. I think the biggest buzz with, you know, medical providers is obviously we live in an era of preventative medicine, but it's also a shared decision-making. You're 82 years old, but you may have a life expectancy of living in your 90s. So for a guy like you, I think it'd be fairly important to, you know, make decisions for you as to whether or not you want to be screened. I would advocate it. If my grandfather was alive and 85 years old and, you know, playing racquetball or playing golf or skiing in the winters, yeah, I would want it to be screened annually. I mean, you hear about a lot of people in the press, a lot of high political figures or athletes who are dying of prostate cancer. You know, leaders of our country not getting PSA screening for a decade and having metastatic disease with a PSA over 1,000. You know, so I think for you, you know, a standard cutoff of an abnormal PSA, I would use your age to kind of help make, you know, decisions as to, you know, how thoroughly we evaluate it and how often we monitor it.
Thank you.
And then you had a question up here.
How dramatic can the scores, the PSA level, the scores change over time?
The PSA as an absolute number is not necessarily the most accurate. You know, many things can alter the PSA, such as, having like an active urinary tract infection, maybe suffering some inflammation in your pelvis and prostate, especially with COVID. We've seen patients with COVID having like a whole body inflammation and their PSA numbers going up. Vigorous activity, bike riding, motorcycle riding, sexual activity can alter the PSA. So we don't really look at the PSA as a single number. We always kind of look at it as a trend, and we can have something as simple as a lab error. So we always repeat the PSA, really holding for a lot of those variables and rechecking it. So we never make decisions based off of one number. We always kind of look at all the numbers and get more testing just to make sure that it was actually accurate.
So what would be the cause for prostate cancer?
So prostate cancer has many causes. The older we get, the higher likelihood of developing prostate cancer. Some of my mentors that I trained with up at Yale would tell patients that if you go to a cemetery and you evaluate 100 men, let's say 60% of them had prostate cancer, of which half of them didn't even know it. Usually it's a very indolent disease process that a lot of men go to the grave with, not because of, but there's various reasons, strong family history, certain genetic syndromes, there's other causes, but the fundamental point is really evaluating how we can monitor it and make sure that it's not becoming clinically significant for the patient.
So in essence, you don't really know what caused it to come about. It just seemed like creeps up.
Yeah, most of it, it's usually just hormonally driven. So it's testosterone driven, and you have a higher likelihood of developing it the older you get.
So that's based on the food we eat.
It's kind of a little bit of a debated topic. There are certain foods that people speculate, but generally speaking, no. Yes.
I've spoken to many physicians, and is there any truth to this notion that if you live long enough, every man's going to get prostate cancer?
That has some truth to it.
Okay.
Of course. If a man goes to a complete physical, must he request the screening, or is the screening included?
Usually the screening is included, but in some ages, some of the medical doctors hold it off because it really has to be a shared decision with the patient.
Like an elective.
Yeah, exactly. If you have a patient who's, 85 years old, has a lot of medical problems, their life expectancy is only a couple of years, generally speaking, a medical doctor may omit that blood test as it may not be actionable, but generally speaking, for a healthy individual, someone who's motivated and wants it, it should be requested. Generally, it's added, to be honest.
Can you briefly walk us through the next steps? If someone have a high PSA, what tests do they need from there? And if they were positive, what are some treatment options?
Absolutely. So I think if as a specialist, we're often sent patients who already have the blood work done. As I mentioned, what we do is we kind of evaluate what your numbers have been and how it has changed over time. And we always repeat the blood test just to make sure it's an actual trend and it's something that we should investigate. If that's the case, as I mentioned, we have a lot of diagnostic tests that we would do that are non-invasive, that are low risk, where we really assess whether or not there is a strong concern. Imaging is a big kind of tool that we use. So MRIs of the prostate are one of the newest things over the past decade that we've been really, becoming experts in, and we use that as a fantastic tool. And we make decisions as to whether or not you need a biopsy. And biopsies, men often when they come to the physician, they think it's the end of the world. They're going to lose their sex life. They're going to, not be able to control their urine. But a biopsy is a simple 5-minute procedure where you get kind of little tiny microscopic tissue just to rule out cancer. We do it at Bridgeport Hospital, one of the most progressive ways in the country, I would say, where we actually take a route called a transperineal route as opposed to through the rectum, where it really mitigates the risk of infection. And it's a fantastic tool that we use. And if God forbid there does show cancer, one size doesn't fit all. We really tailor care to the patient. And Julie is one of our colleagues, or Dr. Kang, sorry, who really specializes in the radiation aspects. Within our Yale health system, we believe in empowering the patient with all of the options. And I usually make the diagnosis, but I always send patients to our colleagues just to, educate you from experts. She's certainly more of an expert in radiation than I am, and probably in medicine than I am. But, we all work as a team, which is fantastic, which is the platform that we have within our kind of local health system. And she's coming next, so she's going to talk more about the treatments. I don't want to ruin her stage.
What is the success rate?
I've heard of cyberknife treatment for the prostate. What is that and when to get it? And is it effective?
I think Julie's going to touch upon that.
Can you briefly touch?
Yes.
What is the impact? You just talked about it.
Yep.
What's the impact of the sex life from prostate cancer?
Yeah, generally speaking, just doing a blood test to evaluate your prostate doesn't affect your sexual function. Doing a biopsy won't affect your sexual function. And even the treatments that we do for prostate cancer that Julie will talk about, really, our goal in medicine is giving patients the best outcomes with the least amount of risk. And I think we've been evolving, even in my short career thus far. Every section of my career has been less invasive, less side effects, better diagnosis, and better treatments and success rates. So that's how we want to practice.
Yeah, I have a question. How do costs affect treatment? I guess, for those who have good health insurance.
Oh, cost.
Costs.
Yeah, as far as I'm concerned, any kind of prostate cancer screening, any kind of prostate cancer testing, and even prostate cancer treatments are all covered by insurance. I mean, I fortunately work for a health system where I don't look at insurance, so I don't look at a patient and say you have X, Y, and Z. We just care about the patient and treating you. But from what I've seen, it's really covered. And Bridgeport Hospital's got such fantastic, patient outreach programs where we have free care for patients. So I see patients and they don't pay anything because we just care about getting the patient in our health system and get the patient treated. So cost should never be an issue.
This may seem like a stupid question, but would there be any chance or concern if you did have prostate cancer transmitted to your significant other? Or
There's no risk of that.
Okay.
And I think I'm getting in trouble. I apologize.
All right, I'm not going to do the introductions like I said. However, I think this is a little bit time for some transparency. I have been diagnosed with prostate cancer last last year. So it doesn't affect your sex life. Right now, my PSA level dropped from 3.8 to 3.4. Then it went up to 3.8. My oncologist is right here. She was handpicked to be here. I'm not in any pain or anything like that. I don't go to the bathroom in the middle of the night. I'm still my same silly self. You can ask my cousin back there. It all happened because of regular checkup, and I have to go to the doctor on the regular because I have high blood pressure. So I go get my checkup every 3 months. My doctor seen that I had a high PSA level, and she said for somebody who was at that time 56, you should go to a urologist. And I went to my urologist. He said, wait a minute, for somebody your age, this is a little bit too high. So I'm like, okay. And then he went and did a blood test and MRI and everything else, and it came back positive. Okay, yeah. So the first day I did flip a script. I'm not even gonna lie, because it was about 12 months after my mom passed from uterine cancer that I was diagnosed, which I was told have no effect. Am I correct, doctor? Prostate cancer has no effect with what my mom had and what it's totally different. So you listen to what they're saying. And then when I met Dr. Kang, she came in with this big old smile and hi, and we're sitting there, we're talking. It was over an hour that she and I had this educational talk about all the options that I had. My Decipher score was low. My there's another score that yes, the Gleason score was also low. It's at 3. So all my scores were low. So as Dr. Kardos was saying, it's called active surveillance. That's what I'm in right now, is active surveillance. So every 3 months I do blood tests. Next blood test is going to be in January. Then after that is going to be in April. So I'm good. I just want everybody to understand that it's nothing to really get excited about right now. Just go get tested, and what the test comes out to be, listen to your doctors. So on that note, the next doctor will be Julie Kang, Dr. Julie Kang.
I did not realize I was handpicked because the only reason I accepted was I saw Dr. Best's name on the email, to be fully transparent. It's absolutely my pleasure to be here today. And if I could just have 2 messages, it would be: number 1, to thine own self be true, which basically means know yourself. And that means knowing about the past, seeing trends, so important. And then the other one is really just, I hope to educate people and not tell you what to do, because it's ultimately the patient's decision. But informed decision making, really understanding what the options are and what they mean for you today and you in the future, is so important. So while I am going to be talking about the benefits of treatment, I'm also going to be talking a little bit about the side effects of treatment, because I'm hearing that I think that's what people want to know a little bit more about. Just baseline, when you're talking about prostate, you have to know about the anatomy, because the side effects of treatment, the risks, benefits of treatment, depend on the area we're talking about. So cough, sore throat, runny nose, and headache are not even possible side effects of the treatment. Okay, so when we're talking about the prostate, we're talking about a genitourinary organ. And what that means is potentially urinary or sexual side effects. The prostate, you can see zoomed in into the large circle, is basically a walnut-ish sized gland. And it's basically a gland that surrounds the urethra, the hose or the tube that the pee comes out of. So your urine is stored in your bladder, and it comes down a hose called the urethra. And that urethra goes right through the middle of the prostate. The other reason you have a prostate is because the prostate has the seminal vesicles, which is where ejaculate is made, which is basically the home of fertility. So sperm comes from the testicles, but fertility, the ability to make ejaculate, to make a baby, comes in large part from the prostate. So the reason I chose this picture here of an enlarged prostate with those little white bubbly tumors is because most prostate cancers are multifocal, meaning starts in more than one place. So the analogy I tell my patients is, if you were to imagine, while the prostate on average is the size of a walnut, the anatomy of the prostate is a little bit more like an orange. So you have pulp and little pieces of fruit and little wedges throughout, and then it's all encased in basically a rind or a peel. So prostate cancers are usually growing at different speeds and in different parts of the pulps, long before they go into the rind, long before they go out of the rind. And this is why most of the time you have a lot of time to make decisions and watch and see what's going on. There's usually not a tremendous urgency with this, but it's really important because we never know on this path when we do diagnose a prostate cancer. Did we find you at the beginning, the middle, or the end? Usually we found you at the beginning, but without some more information, you really don't know till you know, okay? All right. So the analogy I give all my patients when they come to talk to me is to think of prostate cancer, or really any cancer, like a crab. There's the body, the legs, and the eggs of the crab. So for a prostate cancer, the body of the crab, the main part, the center, the origin, is in that small walnut-sized gland called the prostate. The legs of the crab, the fingers, the toenails, where it can stretch, is in the fatty tissue around the prostate or the lymph nodes. And the eggs of the crab, if it can even lay an egg, usually goes to the bones. So it's very true that very few men will ever die of prostate cancer. And in the minority that do die of prostate cancer, they die from the eggs that went to other places. So the name of the game is don't let the eggs be hatched. Don't just do something before we're in egg land. And that's why you also have some time. So the number one thing that Dr. Kardos is doing is making sure that you all don't have girl crabs, because those are the ones that can lay eggs. If we're dealing with a male crab, that's actually something you don't really have to worry about very much. So when we stage prostate cancer, it's a little different from other cancers where you hear the scary numbers 1 through 4. While prostate cancer can be staged in that way, really we talk about it as low risk, intermediate risk, and high risk. I don't want to bore you with all the pictures, but I did want to provide this picture so that those of you who are interested can take a picture on your phone and look at it and think about it. But basically, there are 3 components to how we stage or risk group prostate cancer. Your blood test, a PSA. And if the PSA is a single digit number less than 10, this is considered a low risk PSA. A PSA that's greater than or equal to 10 and less than 20, I guess up to 19.9 or thereabouts, that's an intermediate risk PSA. And if you've ever had a PSA of 20 or more, that's a high risk PSA. Pathology, a biopsy of the prostate. The biopsy scores range from 6 to 10. So I've heard men say, oh my goodness, I have a biopsy Gleason 6. And I tell them, don't worry, there is no 1 through 5. But a 6 is a low risk, a 7 is an intermediate risk, and an 8, 9, or 10 is a high risk biopsy score. And then imaging, scans. So usually the most common scan that we get is something called an MRI, and it's those really high detailed black and white and gray pictures that Dr. Kardos put in his second to last slide in his talk. And basically that's how you get the most detailed pictures of the prostate. And it's really trying to look at what's going on in the pulp, in the fruit, and really what's going on in the rind. If you know you have prostate cancer and if you know it's advanced, you start doing scans that start looking for eggs of the crab in other parts of the body. So not everyone needs one of those body scans. So the treatment options are basically 4. One is surgery. And the common surgery that's basically going to be covered by your insurance is something called a prostatectomy, which removes the entire prostate. The ones that are a little bit more iffy, that may not be covered by your insurance or may not even be available in your state, is partial gland therapies. Removing half the prostate, a quarter of the prostate, or something like that. Why? Well, I think Dr. Kardos and I probably have this conversation with our patients all the time, but we know that about 80% of prostate cancers are multifocal in more than one spot. So why would you go in, treat one spot, leave the other spots untreated, and then have your hands tied when you're trying to come back for the rest of it? So it's really important that when you make a decision to treat, you don't think about just the now. You have to think a little bit about the future as well. With radiation, I am a specialist in radiosurgery. And the brand name, if you wanted to call it Pepsi or Coke, is CyberKnife. And that's basically high-tech radiation done real fast, over 5 treatments. The more standard radiations are done in 6 weeks, which is basically around 6 weeks of medium doses, Monday through Friday, 5 days a week. And then the sort of tried and true traditional, been around for decades, is 9 weeks, very low doses, really long time, still useful on certain people, but not necessary on most. And surgery and radiation both can be used on people who have low risk, intermediate risk, or high risk disease. So surgery and radiation are your main treatments for prostate cancer, and pretty much everyone's eligible, depending on other factors like health, but basically most types of prostate cancer. We really strongly think about surgery and radiation. Hormone therapy. There's two reasons that the men in this room can get prostate cancer and the women cannot. Number one, men are born with prostates and women are not. And number two, the man body makes the natural food for prostate cancer, which is the male hormone testosterone. So why can 1 in 8 men in the United States be diagnosed with prostate cancer in his lifetime? I have to tell you the truth. We don't know, but mostly bad luck, because 7 in 8 won't be diagnosed. Now, if you did autopsies at a cemetery, most doctors think more than half of men would probably have prostate cancer hiding in their prostates that they never knew about. But really, in your living lifetime, 1 in 8 US men is going to be diagnosed with prostate cancer, and that is a lot. And the food for prostate cancer is testosterone, a hormone that your body makes, and there's really nothing you can do about it. So part of the treatment for the more aggressive advanced prostate cancers is cutting off the food supply, which is the male hormone testosterone, a medicine that basically prevents the body from making testosterone or blocks any testosterone that your body would make. Not all prostate cancers need it. And how much testosterone blockade a prostate cancer needs really depends on the cancer itself. But this is just here to know that it is a possible treatment. And oftentimes the hormone therapy is added on to one of the others, like the surgery or radiation. It's kind of a may need to opt in, may not need to opt in situation. And then the final treatment for the people who have low risk or very, very early intermediate risk disease is active surveillance. You watch it. If you just got diagnosed with something very early, how long is it going to stay this low risk and this well behaved? Statistically, many years. I mean, anywhere from 1 year to 15 years, I have seen people stay at a low risk or a very early. I don't know. Dr. Kardos would probably know the average better than me. I think average is probably something more like 5 to 7 years, but I mean, it can be low for quite a while. So just to kind of show some pictures, because I'm running out of time, the surgical options, one called TULSA up there is partial gland therapy. And this is something that doesn't treat the whole prostate. The standard of care, the gold medal treatment, is removing the whole gland. Robotic surgery is something that I think Dr. Kardos here at Bridgeport Hospital probably does more of than maybe anyone in Connecticut. So this is, I've never seen this treatment not covered, okay? As a rad-onc, I've never seen it not covered. And then internal radiation, if y'all have heard the word seeds, the left is internal radiation where radioactive seeds are put in the prostate and stay there until they basically kill the cancer with radioactivity being given off. This is the more fancy kind called interstitial, and I'm not aware of this even existing in Connecticut, although we did have it in New York at Memorial Sloan Kettering. Most of the people who see all those needles and procedures, they say the whole reason I was interested in radiation is I didn't want all that. So this is the more conventional radiation, which is you lie down on a machine and the machine moves around you. And just these pictures are showing how the technology has progressed over time so that the radiation gives very little, that dark blue rim, it gives very little outside, but it adds up to a whole lot in the middle at the red where the prostate is. The main side effects of this type of treatment as far as urinary symptoms are concerned is things that are like frequency or a weaker flow or a slower flow, maybe some urgency. But in general, these side effects last for a couple months and they do go away. And in the long run, after the treatment, most men actually pee a little faster and better because the radiation will shrink the prostate because it scarred it down. So the risk of incontinence after radiation, needing a pad or a diaper, is less than 2%, very low. Now, sexual function, if you do not need hormone therapy, do not want to do hormone therapy because you feel pretty good and you'll just take it if you need it, but you don't want to do it now, you will have none of these side effects, you could just close your eyes and look the other way. But if you have the type of prostate cancer that needs hormone therapy, or you want to opt in, low testosterone is the side effect of hormone therapy. And the most common side effects of that are erectile dysfunction or loss of libido, loss of interest, as well as possibly like a slowing of the metabolism. The reason men have more muscle and less body fat than women is testosterone. And so you would have these side effects while on the testosterone blockade therapy, but they should get better after you're done. And then active surveillance is active. That's what PSA looks like on crystallography. It's a blood test, and maybe an MRI or a biopsy. Above, you'll see a CAT scan. Below, you'll see an MRI. I think you can see which one looks a lot more detailed. And this is why technology is our friend. Screening and surveillance have gotten so good, so that we really don't lose people in between, in the cracks. Thank you.
Thank you, Dr. Kang. Our next doctor is going to be Dr. Daniel Lavy.
So my name is Dr. Daniel Lavy. I'm a colon and rectal surgeon here at Bridgeport Hospital. Today's talk, we're going to talk a lot about colon cancer. What is it? What you can do to prevent it? What diet, lifestyle changes that you can make starting today that may actually decrease your risk for colon and rectal cancer. So we'll start off very basic. We'll talk about what is cancer. Cancer is when the body's cells, they start growing out of control. Normally, cells grow, they do their job, and then they die when they're supposed to. That's what normally happens. But cancer cells don't really follow those rules. They keep growing and dividing, even when the body doesn't need to. Over time, these extra cells, they form a lump. We call that a tumor. That can spread to other parts of the body, making it harder for your normal organs to work properly. So here, this is a normal representation of your digestive tract. All right, you swallow something, it goes in your esophagus, then your stomach, and then after your stomach, it goes to the small intestine. That's where all the nutrients are absorbed. And then it goes to your large intestine. And there's several parts. Part on the right side, we call that the ascending colon. Part that comes across, we call it the transverse colon. And the part that comes down on the left side, we call it the descending colon. It makes a little S, we call the sigmoid colon. And this here is a picture of a cross section of the large intestine colon. And you can see that these little polyps are here. All right, these lumps or growths that can grow in your colon, they're called polyps. 20 to 30% of adults have at least one polyp present. And a small percentage of these polyps can then transition to cancer. So why does any of this matter? So colon cancer is the third most common cancer worldwide. It affects both men and women. The risk increases with age, just as we saw in other types of cancers as well. And detecting these polyps, these growths that could potentially turn into cancer, can save lives. So we'll talk about how we do that. So who's at risk for developing colon cancer? Those over the age of 45. If you have a family history of someone in your family with colon or rectal cancer, or a family history of polyps, certain genetic conditions like Lynch syndrome, or inflammatory bowel diseases like Crohn's or ulcerative colitis can increase your risk up to 8 to 10 times. Certain diet and lifestyle factors have also been shown to increase your risk for colon and rectal cancer. Diets high in red or processed meats, diets low in fiber, smoking or alcohol use, lack of physical activity, and obesity can all increase the risk. So what are the symptoms of colon cancer? Well, many times there are no symptoms. That's why screening tests are very, very important. But sometimes people can present with symptoms. Sometimes it's a change in your bowel habits. If you've had normal bowel movements every day, once a day, and all of a sudden you start having constipation or diarrhea or change in the caliber of your stool, blood in your stool, whether it's on the wiping paper or in the toilet bowl, persistent abdominal pain, cramping, bloating, unexplained weight loss, fatigue, or weakness. And I think also it's a qualifier here, just because you have any of these things does not mean you have cancer. I think all these things, they warrant a conversation with your physician to kind of determine what the next best step would be. And of course, a physical exam. So we'll talk about that screening. How do we screen for colon cancer? Colonoscopy, that's the gold standard. That's what our general recommendation is that most people should do. What is it? It's a camera. And it's a camera that's on a thin, flexible tube. It's inserted into the rectum while you're asleep, and it allows us to view the entire colon. We can see these polyps, and we can remove them at that time while you're asleep, thus preventing progression to colon cancer. The good things, it's the most accurate test. We know it prevents cancer. And if it's normal, we usually do it once every 10 years. The cons, it does require a clean out the day before. It does require some anesthesia, although some may view that as a good thing where you're completely asleep for a couple minutes. There are some small risks of the procedure, but those risks are less than 1%. Patients often need the day off from work and somebody to drive them there and back. And we do them here at Bridgeport Hospital. So you may also read about alternatives to a colonoscopy. And these are mostly stool-based tests. And we'll go through some of them because you may read about them. And they are alternatives, but they're not as good. So the FIT test, this detects hidden blood in the stool. It could come from polyps or cancer. If you're going to do this, we recommend you do this yearly. It's a simple at-home test. There's no prep. There's no sedation. It's inexpensive. Those are all the good things. But the cons are, needs to be done every year. It only detects bleeding, which can come from many other things, hemorrhoids, stuff in your diet. And if it's positive, you still need to do the colonoscopy. The guaiac-based fecal occult blood test, same principle, except a much older version of the FIT test. It's also same good things about it. It's done at home. It's simple. It's inexpensive, but it also needs to be done every year. And if it's positive, you still need to do that colonoscopy. Cologuard test is something that's become more popular. It's also done at home. It's a box. They bring it to your house and then you mail it off. There's no preparation or anesthesia. It's a better test than any of the above two. The way it works is actually test the stool DNA to detect abnormal cells shed by polyps or cancers. The downsides are that it actually has a very high false positive rate. False positives can give people a lot of anxiety. All of a sudden, you get this positive test, you think you may have cancer. And what happens next? You still got to do the colonoscopy. Also downside is it's very good at telling you, do I have cancer or do I not have cancer? It's not very good at detecting the polyps. And what happens? Polyps, they're precancerous. So you could be missing something. CT colonography is something you may read about. It's a CAT scan that does 3D images of the colon. There's no sedation. And if it's normal, we would screen you every 5 years. However, it still requires a clean out the day before. And if polyps are found, well, guess what? You still need the colonoscopy. Also, it's not very good at detecting smaller polyps, those less than 5 millimeters in size. And on the colonoscopy, we'll often see polyps 2, 3, 4 millimeters. So the takeaway from this is the colonoscopy, it's the gold standard treatment. If there's a specific reason why you cannot have the colonoscopy, there are good alternatives, but they're not as good. And any positive result from these tests will warrant a colonoscopy. So here's a pictorial representation of what a colonoscopy is. You lie on your side. There's the flexible camera here that's put on a tube. It goes into the rectum and it screens the entirety of your large intestine, which is roughly 5 feet. And you can see we have a video screen that sees the inner lining of your large intestine. And this is an actual picture of it as well. And this is what a polyp looks like. Looks like a little growth that comes from the inner lining of the large intestine. So when should you start and how often should you get it? So the general consensus recommendation is if you're 45 years or older, you should start screening, whether you have symptoms or not. And we would continue this until the recommendations are loose, just as prostate cancer, till the age of 75. But this is a conversation between you and your physician. And if you have an estimated 10 years of life, then it's worthwhile. And this is definitely a conversation, and those are guidelines. They are not fixed recommendations. Higher risk groups, we may screen you earlier, especially if you have a first-degree relative with colon or rectal cancer or advanced polyps that are diagnosed under the age of 60. If you have a personal history of Crohn's or ulcerative colitis, we would start screening you sooner. And the interval between the colonoscopies would be shorter, and genetic conditions as well. So, what can you do to prevent or decrease your risk for colon cancer? Number one, eating a high fiber diet. We call this a plant-forward diet. Aim for fruits, vegetables, whole grains daily. The whole thought process behind this is that fiber is a stool bulking agent. It helps move food and stool through the colon faster and may reduce contact with some carcinogenic substances. 2, limit red and processed meats like bacon, sausage, deli meats. Frequent consumption is associated with a higher colon cancer risk. Now, I am not suggesting by any means you have to eliminate all this stuff, but the studies show that over 50 grams a day for a very long period of time can increase your risk. All right. So if you can limit some of that, that's been shown to be somewhat protective. 3, exercise regularly, staying physically active, regular exercise. It's been shown to be protective against colon cancer. The guideline is about 150 minutes of moderate activity per week, but anything is better than nothing. Long-term smoking increases the risk for many cancers, including colon cancer. Quitting benefits your health no matter how long you've smoked. 5, stay on top of screenings. This is the most effective prevention because it finds and removes precancerous polyps. You know, people often ask me, you know, what's the best one? What's the best screening test? What should I do? And the answer is the one that you're actually going to do. So whether if you're not into the colonoscopy, you can't do it, then the alternatives are fine. There are better tests, but whatever you're going to do regularly is the best test. So I think the key takeaways from this, it's common, but it's preventable. Many cases, they start as polyps, which can be removed with a colonoscopy. Even if you don't have any symptoms, start screening at the age of 45 or earlier if you have a family history, and definitely have a conversation with your doctor as to if you should start sooner. And early action gives you much better outcomes. Any questions? Yeah, was there a question also? Yeah,
I see.
of course.
About the first degree relative,
Yes.
that would be,
So first degree would be parent, child, or sibling. Those are first degree relatives. And you know, it's either one first degree relative diagnosed under the age of 60 increases your risk, and we would typically start 10 years before the age they were diagnosed. So if they were diagnosed at the age of 50 with colon cancer, if a parent was, we would start your screenings at 40 instead of 45.
so now in a grandparent, that doesn't count.
So it's actually, yeah, 2 second-degree relatives under the age, at any age, would increase your risk. So just one grandparent would increase your risk. So, you know, the real answer is, why does this happen? Why does cancer happen? Why does prostate cancer? Why does colon cancer? We don't know why. You know, we call it multifactorial. You know, oftentimes there's a genetic component, but there's also some environmental factors that we haven't really figured out yet. We're doing a whole bunch of studies. You know, if any of you are interested, if you know people, a young patient under the age of 50 diagnosed, we're seeing a ton of new cancers and we don't quite understand why. The newest research suggests that it's actually a bacteria that you're exposed to when you're 3 or 4 years old. And about 30% of patients exposed to this bacteria will go on to develop cancer, but nothing's for sure yet, and we don't really understand. So yeah, you can do all this stuff. You can never eat a piece of bacon in your life. You can exercise for 100 hours a day, you know, and you can still get this stuff. And that's what's most upsetting to us too. So we don't have all the answers, but we do. There are some forms that are preventable.
Thank you. I learned that my grandmother died of colon cancer back when I was a child and thought that was a man's thing. But now that I'm over 80 and you say 75, but now I should talk to my doctor about.
Absolutely. Absolutely.
Okay.
Any other questions I can answer?
What's the reason for sedation for colonoscopy?
It's a little bit uncomfortable if you did it awake. Many years ago, we used to do it awake. It's a camera going up your bottom, and you know the medication we use, you don't see, feel, hear anything. Takes about 25 minutes, and you are out. And that way, we can really look. We can take our time. We can look, and if there are things we see, we can take them out. So I would want to be sedated for this procedure.
Yes.
Little.
Yeah.
You talk about the large intestine. What's the impact, if you will, on the small intestine?
What's the impact?
What, if from a cancer standpoint, we're talking about the large intestine, the colonoscopy is only on the large intestine. What about the rest, those miles of
Small intestine? Yeah, it's hard because, you know, if we do endoscopies that look at the esophagus, and we do colonoscopies that look at the large intestine, but there's a little bit of no man's land where it's hard to screen. Small intestinal cancers are actually very rare.
Okay.
So we don't typically recommend routine screening for those. Very, very rare across the country. So it's not something that you guys need to actively screen for.
Thank you.
Thank you, Dr. Lavy. There's screenings out there. So after the symposium's over, there's right around the corner. You can go and see about screenings around the corner. And we also have a door prize giveaway that we're going to be giving away. And the next doctor that is up right now is Dr. Daniel Rudolph.
I'm sorry. Here. Okay. Thank you. I'm Daniel Rudolph. I've been in Bridgeport Hospital since 1985, working on the services, the pulmonary critical care services. And I was fortunate enough to join with some colleagues in the lung cancer screening program that's been developed that we coordinate at Park Avenue. And let's talk about some screening. There we go. Thank you. Lung cancer screening is a 10-minute imaging. We have many different sites in our community, including Park Avenue, Milford Hospital, Bridgeport Hospital, and other places where if you come in an hour, you put on a gurney, you roll through an imaging, and in 10 minutes, we have a beautiful picture of your lung. And in that picture, if you're a smoker, there's an opportunity to find a curable cancer. I have the I'm very fortunate to work with a number of great physicians and nurse practitioners. We have one here, Stephanie. Thank you. Stephanie Miller works with me in my clinic. You see patients, she organizes screening. I have a surgeon, Vinnie Mace, who is not here, but he trained in Texas, is a trauma surgeon, chest surgeon, works in our clinic. And if you're unfortunate and have malignancy and you have to have a surgical procedure, he's a wonderful surgeon and he's available. Our last but very important addition to our crew is Nora Hutton, who joined us recently and is an outreach. She spends time in the community educating our community about our services. But I can't forget Jean Brown, who's sitting up front, who's our general manager. She's developed the programs, coordinated our programs, funds our programs, and without her, I don't think we'd be as efficient or as successful. Okay, who should we screen? We're looking for higher risk patients. We're looking for people that are smokers. Anybody who's smoked for 20 years, a pack a day, or currently smoking is a candidate for screening. Now, most people who come to the clinic don't remember how much they were smoking. And very often it takes a time to really determine the risk. But we try our best to make sure that everybody's screened that is qualified. Now, if you quit smoking 20 years ago, there's a question whether you should be screened. So people who have a remote history of smoking sometimes are not screened, but we look very carefully at their past and see whether they could be screened and are a candidate for this life-saving screening. Most people who have lung cancer that is early stage have no symptoms. Very often they come to the clinic and we discover they have other types of respiratory diseases. Some of the symptoms that we see are coughing, chest pain, shortness of breath. These are people that have been smoking for many years. Most of the people that we're screening, though, are asymptomatic. They don't really know that there could be a dangerous malignancy. The risk factors are significant, and if we screen them, we can find a small malignancy that is easily cured. Lung cancer, as you probably have heard, is a leading cause of death in our country. It's a very common disorder. I've seen in this community a huge increase in the number of people that are diagnosed. Now, unfortunately, screening only is being used by approximately 20% of the people in our community. That's where we need your help. As Ann said, this is a call to action. We need the community members. Reverend Best, your community, thank you for bringing everybody. I'm hoping that you will be able to share some of this information with your friends, family. The people that are at risk are smokers. They need to be seen, screened, identified malignancies that are curable. I thought I'd bring a few cases from our clinic. When we do CAT scan imaging, what we do is we take a slice of the lung. It's like cutting you in half and taking a look at what's inside your lung. On a routine chest X-ray, very often we don't see these small nodules, which we can easily see on a CAT scan image. Now, if you look here, we had a 77-year-old woman come to our clinic who was screened a former smoker. And as you can see in the right lung, we identified a small nodule, probably the size of a lima bean. But by its appearance, it's clearly a lung cancer. So what do? Well, we usually consider a biopsy or further imaging called a PET scan. And if we determine, based on our imaging, that this is cancer, we decide to refer them for treatment. Treatment options can include radiation, surgery, and rarely chemotherapy if the disease is advanced. Fortunately, this nodule was discovered early. Patient was referred to radiation oncology, received radiation that probably took about 2 to 3 weeks and was cured of her cancer. I had one more case here.
Just move the mouse down.
There we go. This young woman came to our clinic, a 63-year-old woman, and had lung cancer screening. And as you can see, where the arrow is pointing in the left lung, there's a small nodule the size of a pea. This obviously would not be seen on a regular chest X-ray. And she was referred for surgery. Benny Mace saw the patient and she had a resection of her left lung. and as a result, a curable procedure, and she's cancer-free. Now, over the course of the year, we've had numbers of people come. I think we screened thousands of people, and out of that thousands of people, we can find a good number. I think we've had 10 to 20 people who had stage 1 or early stage cancer that was cured. Number of people came to our clinic, had more advanced diseases, were referred to oncology, and had early treatment of diseases that can progress very quickly. Another important fact is that a lot of the people who come to our clinic have chronic lung disease from smoking. As you probably would recognize, the risk of smoking is not just malignancy, it is chronic lung disease that includes asthma, COPD, chronic coughing. And a lot of these people have never seen physicians who come for screening, and we're fortunate enough to refer to a good number of pulmonary specialists in our community that will take care of them and treat them. And that's been a great addition to the screening that we have available. So in summary, 10 minutes of your time, if you have a risk for malignancy, if you have a risk for lung malignancy, if you're a smoker, can be life-saving. So we would like in the next years to expand our clinic. We need the help of the community. We have Nora with our outreach, and hopefully we can expand the number of people screening and save more lives. Does anybody have any questions? Go ahead.
Yeah, I have a comment. I think telling people that they're cured of cancer is dangerous.
Sorry,
Telling people that they're cured
is dangerous.
Dangerous statement. People who had cancer and it came back again, and it took them.
Oh, yeah. People who have cancer.
Lung cancer.
Oh,
Doctor told him he was cured.
yeah.
He came back and took. I think that's a dangerous statement to make.
I think that if we look at the numbers of people that have early stage lung cancer and have intervention like surgery or radiation, we have cure rates of 90%. Yes, we don't tell them they're cured. We tell them that we successfully treated their cancer. And of course, they all come back for surveillance. So none of these patients, and I think that this would include your friend or family member who had a cancer, is abandoned. They are put in a system of follow-up. And sure, there's a significant risk of recurrence. But in this particular case, in stage 1 cancers, we've been exceedingly successful in curing a large number of people who do not have recurrence. There are a percentage that recur.
I'm not just talking about, I'm talking for myself as well. I'm a 2-time cancer survivor. And I remember talking to my doctor and saying, you know, is there any such thing as being cancer-free? She says yes until it comes back again. So so you have cancer, you get.
Yeah, agreed. And also, what's also important, you make a good point, is that other malignancies are common in people with lung cancer. So if you have lung cancer, you're at risk for prostate or colon cancer. The statistics are such that you have to be screened for all forms of cancers. Bladder cancer, you need urine analysis. Prostate cancer, you need your PSA test. Colon cancer, you need, every 5-year colonoscopy. So you're right. You're not cancer-free in the sense that you don't have risk of recurrence or other cancers. But in terms of this early stage cancer that we're looking to treat, we're very successful at eliminating the recurrence rate.
Question, with regard to lung cancer, you were screening people that smoke. I was wondering the significance of secondhand smoke.
Good question. We're not exactly sure the risk, but there is a risk. So we find in people that have lived with people that are heavy smokers, the risk of lung cancer is greater. We can't define it in terms of numbers because when we're looking at statistics, we're looking at people who are heavy smokers, 1 pack a day for 20 years when we look at the data about lung cancer. So it's hard to get a handle on the risk, the risk number of people who are living with smokers, but it is at risk. They're at risk. And there's other, in this community, as a matter of fact, there's another group of people that have high risk of cancer. That includes people that worked at Rev.Dr. I've been here long enough to have seen a large group of people, men and women who worked at Rev.Dr. who come down with lung cancer 20 years after they've been in the factories. So the factories in Bridgeport, the exposure to metal dust, asbestos, and chemicals carry significant risks. And our community, unfortunately, since manufacturing was very big here, has had a large group of patients that suffered from that exposure.
What about the incidents as we have a growing use of marijuana, et cetera? Tell me about the impact of marijuana, because it is a type of smoking, if you will. So
Yeah.
could you talk to me about that, please?
Yes, that's a very good question. Since marijuana smoking is much more common now, we know that there is risks of both marijuana smoking and vaping in terms of chronic lung disease. We don't have the statistics about lung cancer, but clearly if somebody is smoking daily marijuana, the risk of lung cancer is higher. I can't give you the numbers, but it certainly is a risk. And vaping, of course, now is bigger over the past 5 years, particularly in the younger people. We see a few that have damaged lungs, not cancer, because we're talking about 20, 30-year-olds that have daily vaping who end up with chronic lung disease. We haven't really followed them long enough to find out exactly the risk of malignancy, but there's clearly a risk.
So the different cancers have ran in the family, male, female, whichever. Is it possible that the younger person would have to get checked as well, or how young should they start getting checked? Like, for instance, I've had cancer 3 different times. Should my son start looking to be checked for any kind of cancer because I've had different cancers?
In terms of lung cancer, it's more related to cigarette smoking or occupational exposure to dust or chemicals. Or
say to the other gentleman that if you've had one cancer, you should be checked for.
Yes. So if you're a cancer survivor or have cancer, we know that the risk of other forms of cancer is significantly greater. The oncology groups that I work with are very careful about making sure that they're screening their patients for other malignancies. I know a lot of people that are treated at Smilo by oncologists or the specialists who treat tumors who are very careful about screening for other cancers or making sure that the primary care doctors are screening them, because there's an important relationship between the cancer doctors and the screeners and the primary care doctors. We need to maintain those connections. In our particular clinic, I have a superstar, Stephanie Miller, who makes certain that that loop is closed, because you're right. The person with cancer has to be carefully looked at for other cancers.
Thank you.
Question, those that receive prescription for marijuana, are they subject to lung cancer too? They use marijuana, they claim for pains and all this kind of stuff. Is that
So you mean pain medication?
subject to lung cancer?
You mean,
You'll be smoking this stuff.
you mean pain medications or smoke? I'm not sure I understand.
Medical
marijuana.
Sorry. Medical marijuana is also an inhalant. We don't know the degree of risk. There are people that are using it regularly for treating cancer symptoms, but we're not really sure about their risk profile, and we don't usually screen patients who are marijuana smokers or who have medical marijuana. The insurance companies will cover lung cancer screening for smokers. They don't cover lung cancer screening for marijuana smokers or medical marijuana smokers, unfortunately, as a clinician. If they have chronic lung disease related to marijuana smoking or vaping, very often we will screen them anyhow, even though the insurance companies or the criteria for risking is not met. So there's a whole group of people with chronic lung disease, which I think you're getting at, who have other forms of risk other than cigarette smoking, then end up having CAT scans. And of those group of people, there's a good number who have chronic lung disease that are identified with early stage lung malignancies that we can treat.